Dr. Jay Sridhar from the Bascom Palmer Eye Institute in Miami, Florida, and I have the pleasure of bringing you New Retina Radio Journal Club with the Bit-Buckle Society VBS. I'm joined by three friends and colleagues from around the country. First, in alphabetical order, Dr. Sabin Dang. He's from the Retina Institute in St. Louis, Missouri. Sabin, welcome.
Thank you, Jay.
Next, we have Dr. Brian Doe. He is in Retina Group of Washington and Washington, D.C., and he is an assistant professor of ophthalmology at Georgetown University. Brian, welcome.
Thanks, Jay. Good to be here.
Last but not least, we have Dr. Avni Finn from the Bay Area. She is part of Northern California Retina Vitreous Associates. Avni, welcome.
Thank you, Jay.
So we have a couple exciting articles to touch on regarding everyone's favorite topic, retinal detachment surgery. And we're going to jump right in. The first study we're going to talk about is outcomes of primary rhegmatogenous retinal detachment repair with extensive scleral-depressed vitreous removal and dynamic examination. This was by Bagaj et al. Avni, tell us a little bit about this paper and what they showed.
Sure. So, I think the premise of this paper is basically that there's extensive debate about how much vitrectomy we need to do, right? So how much peripheral vitrectomy, vitreous shaving do we need to do to successfully repair a primary retinal detachment with vitrectomy? So the goal of this study was really to look at and report the outcomes of patients undergoing retinal detachment repair using small gauge vitrectomy and performing what they called extensive scleral depression with vitreous removal and dynamic depression. This was a single center study at an academic medical institution, and they looked at surgeries performed by 3 different surgeons, and it was retrospective in nature. And these patients underwent vitrectomy alone or vitrectomy with scleral buckle. And all of these patients underwent what they called an extensive vitreous removal with dynamic depression. So they defined that in the paper as far peripheral vitrectomy over the ora sebrata, extending 1 to 2 millimeters posterior to the posterior vitreous base with slow moving anterior to posterior scleral depression. They did exclude patients who had surgery before, and significant PVR, so grade C PVR, any sort of neovascular PDR associated RD, trauma, and uveitis. And their main outcome measure was the single surgery anatomic success at 3 months, and then final reattachment at last follow-up. They also reported their visual outcomes. So in total, they included 187 eyes. 159 of these eyes were vitrectomy, and 29 eyes got buccal vitrectomy. And they showed a really high single surgery success rate. So 99.5% of these patients had a single surgery success rate for all eyes at 3 months, and 100% at final follow-up. And of these eyes, 116 of the 117 initially MAC off detachments were reattached with 1 surgery, and all of the MAC on detachments were reattached with 1 surgery.
Great summary. And so I think limitations, again, always really important for any paper to discuss. Any big limitations before we dive into the discussion?
Yeah, I think there are several big limitations for this study. One is that it's, one site or one institution, and there are, again, the surgeon factor, where you have 3 different surgeons performing surgeries. You also have different fellows who are the skilled assistants performing the scleral depression, or vice versa. And obviously for an extensive peripheral shave and dynamic exam, that scleral depression is really important. So who is doing that plays a big role in your visualization and your ability to perform a thorough vitrectomy. So I think that's probably the biggest limitation that I would point to in these patients. And then, controlling for the type of detachment, which I think really wasn't, it's difficult to control for in this type of study. So, how much, the extent of detachment, quadrants involved, that type of thing.
Yeah, great points. And I think always a lack of a comparison group is also, you referenced that this is just looking at patients who had this shave technique. It's impossible to match completely because one patient can only have one type of surgery, but it's always an interesting question because the people who shave versus people who don't shave, the people who don't shave say, well, if I don't shave, I get the same outcomes that you do. But I'll say their success rate's very impressive. I mean, there aren't many studies that show a success rate essentially hugging 100% for single surgery anatomic success rate. You mentioned the assistant. The other thing that was interesting is the vacuum settings. They reference their cut rate is maxed out their vacuum, and it's regardless of what machine everyone uses. We don't have to talk about which machine. They all kind of similar mechanics. You know, some machines have like a shave type mode where two things happen. One is the duty cycle decreases, which is how often the cutter is open. But the bigger change is the aspiration decreases. I'll be honest, I'm actually more on this spectrum. I learned from one of my attendings fellowship. I don't actually switch modes to a shave mode. I don't really use a shave mode. I just use the same mode and modulate with my foot pedal how much vacuum I'm applying. But it's pretty rare I'm applying max vacuum the whole time. So I don't know what they're referencing here, if they're using that max vacuum the whole time or they're modulating that, but that's the setting on the machine, in which case the vacuum could be anywhere from 0 to 650. But Sabin, any thoughts on like vacuum settings? And again, the idea of qualified assistant, now that you're, if you're in a setting where you don't have fellows or you don't have someone who can assist you, that obviously changes your ability to apply this technique.
I'm going to talk about vacuum settings first. Jay, I do what you do. I just stay on my core vitrectomy mode, and I just use my foot pedal to modulate the amount of vacuum I'm using in the periphery. The time I actually do use shave mode is actually with my fellows, particularly early in training when they're beginning to shave. I want to have that hard cap. I don't want them to have full access to that 650 vacuum, because I think what we're all getting to is, in the wrong setting, if you put 650 vacuum in the peripheral retina with maybe some fluid there, you're going to make more breaks and you're going to give yourself a harder time. So in those cases, I think especially when fellows are early on, capping them at something like 300, and as Jay said, just adjusting the duty cycle, giving them a safer environment to work with so they just can't really get themselves in trouble. But if an experienced VR surgeon, I think what they're suggesting is probably proportional vacuum with a 7500 fixed cut, which case I would feel comfortable. I don't think I would ever really use the 650, but I have it there for when I need it. Also with fellows, I mean, this technique is going to be really good at removing the peripheral gel and getting nice and clean, but you have to have a really good assistant. And it's not just like a scrub nurse is going to be able to help you do this. They really need to be engaged, looking at the scope, predicting where you're going to move your cutter next. Because as we all know, if someone depresses too aggressively all of a sudden or makes some sporadic movement, we can induce some pretty severe iatrogenic injury. So I don't think this is a completely transferable technique to the vast majority of retina specialists in the country. The people on this call here we all get the benefit of having fellows, so I think we could use this. But what about every other retina specialist out there who doesn't have the access to the qualified surgeon? Makes it hard to see how this would be applicable to them.
Great points. And I think that that's something we forget about sometimes, quote unquote, in the ivory tower, when we're surrounded by capable assistants. And I'll be very honest, and we can get into the end what everyone kind of does in terms of shaving. I think that I actually shave most of my detachments, and I wonder if I would do it if I wasn't teaching, because I feel like I have to teach people to shave so they're able to know how to shave for when they need to do. I don't know if it influences the outcome. I think it's reasonable if it's safe, as you said, and you're not creating peripheral breaks and it doesn't add excessive times, you get efficient with it. I think it's reasonable to do it while you're in the surgery. I tend to do it, but it's really hard for me to point to data that tells other surgeons that they should do it. And this may be an example, but there are some limitations. I mean, we talked about the lack of comparison group. It's also interesting that it's a retrospective study, Brian, but again, there's 3 different surgeons. How do we know everyone's technique is exactly the same? Now, maybe they came together afterward and like, oh, we all do the same thing and let's publish this paper and report our results. But what do you think about that component?
I mean, it's again, it's difficult to say, not having been in the room when, these folks were having a discussion about putting this study together. It's hard for me to imagine that, they sort of had a checklist in the operating room and said, this is exactly how we're going to shave every single case. When it comes to cases like this, standardization is difficult. You might say in your operative report that, scleral depression and close shaving of the vitreous base was performed, but, everybody has different thresholds for what a close shave is. And, I think until, or, unless we have better ways of imaging the vitreous and sort of doing volumetric analyses of residual vitreous and things like that, it's just sort of taking somebody's word for it, unless you're actually going into the eye and seeing how much vitreous is left. So again, I suspect that the methodology that they used for performing these procedures was at least similar in philosophy. But I can't imagine that, it was sort of like, they were being methodical about doing the same exact thing for every case, especially because it was retrospective in nature.
Yeah, and I agree. And people have tried to report volumetric analyses of how much vitreous they removed and say, oh, this is how much I collected at the end of the surgery. But that assumes you never were in water. And if you're a very experienced surgeon, you probably minimize the time you're cutting BSS or doing a BSSectomy, as some of my attendings called it. But you're still probably never completely efficient. I think I always also like this, you're almost always overestimating the amount of vitreous you remove and underestimating the amount of vitreous you left, especially in a phakic patient versus a pseudophakic patient. Do people stain routinely? I usually actually use a steroid. I use preservative-free triamcinolone to stain. Avni, do you use a steroid routinely? Are there certain cases you select a steroid for when you're treating a retinal detachment?
I don't use a steroid routinely, but oftentimes when I actually don't have a skilled assistant, and I find that actually using a steroid to stain the peripheral vitreous does help me when I'm by myself, or using a chandelier to help myself depress and do peripheral shaving, really visualize that peripheral vitreous better. So I think that's one of the ways to kind of control a little bit more for how much peripheral vitreous you're removing is staining it and really seeing yourself remove it. They did make that point actually in this study that using triessence or Kenalog to stain the vitreous and really making sure there's a thorough removal of the vitreous can be helpful.
Sabin, what are your thoughts on steroid staining? And then they had a lot of these cases get buckles or vitrectomies. They report kind of a high success rate regardless using the technique, whether they had the buckle or not. It's really hard to compare 99% versus 99% essentially. Thoughts on either steroids basically the lack of an effect of a buckle seen in this paper?
Yeah, so I mean, for the lack of a buckle effect, I think these are highly experienced surgeons and they chose complicated cases that needed the buckle to achieve their success rate. At the end of the day, you can't do stats on 99% versus 99%. So I think they probably looked at these patients who are phakic, where we won't be able to get this aggressive shave in a phakic patient with a dense NS and really be able to visualize out there. I'm sure those are the patients that kind of skewed towards buckling to get this high success rate. I think the use of Kenalog or any sort of steroid is important in these patients. I don't use it routinely personally, but I have a very low threshold to kind of add that into an eye if I'm ever in doubt. Did I get all the peripheral gel out? A lot of times with depression, I can visualize it. But again, in these dense cataracts, sometimes it's just easier to put a little Kenalog in and see what you're really left with.
And last point, if you're feeling depressed about your outcomes, we should also strive for that 99% they achieved. Maybe these cases were not, there's some complexity in them, but posterior vitreous detachment, 92% of these patients had a PVD, and that probably influenced their decision to do a vitrectomy. Makes it a whole lot easier to fix a detachment when you have the hyaloid up to start. And that reflects good case selection. I'm not criticizing the surgeons, but that may influence the final success rate. Well, thank you guys for contributing to this discussion. We're going to take a short break and we'll be back with a couple more papers after the break. So let's move on to this next paper, which is factors associated with the use of a 360-degree laser retinopexy during primary vitrectomy with or without scleral buckle for rhegmatogenous retinal detachment and impact on surgical outcomes. This is pro study report number 4. Brian, I'm going to challenge you to say that 5 times fast, but in reality, I'm going to ask you to talk a little bit about this paper and the results.
So Jay, we've previously discussed, the pro study and a couple of the papers that have come out of it. I don't want to sort of, beat a dead horse, so I won't go over necessarily all the methodology that they use to put these data together. But as they've done for previous papers, they looked at single surgery anatomic success at 3 months. In this particular case, they looked at final anatomic success. And these were folks who had a vitrectomy with or without scleral buckle in the year of 2015, and they drew from the same 6 centers that they did for previous studies. They, in this case, looked at some secondary outcomes. They looked at final logMAR visual acuity. They looked at number of subsequent surgeries required, as well as epiretinal membrane formation and presence of cystoid macular edema, at the final visit. And so, they were able to identify some factors that were associated with the use of 360-degree endolaser. In this particular study, they had 1,347 patients who underwent primary vitrectomy, 901 who underwent combined buccal vitrectomy. Of the vitrectomy group, 315 patients had 360-degree endolaser, and in the combined group, 201 had 360-degree endolaser. So factors associated with endolaser, 360-degree endolaser use were a younger patient age, a number of retinal breaks, extent of RD. So, more clock hours of RD, was likely to lend itself to use of 360 laser, and surgeon identity, where some surgeons tended to do it more frequently than others, which is, the way that it goes for most of us. We all have the things that we like to do surgically and sort of stick to what we have in our bag. 21% of the surgeons included here performed 360-degree endolaser the majority of the time. And this seemed to be more common in certain institutions. And the farther out these surgeons were from training, the more likely they were to use endolaser, which I find interesting. I don't know if it's, just having been burned by, secondary breaks, too many times, having been heartbroken by PVR, things like that. Interestingly, they found that single surgery anatomic success rates were not significantly better in folks who had 360-degree endolaser at 85.4% with and 86.7% without. This difference wasn't statistically significant. Final success rates, interestingly, were significantly different. So folks who hadn't had endolaser or 360-degree endolaser had a 98.3% final success rate versus 94.9% in those who had. And there was also a significantly different, better visual acuity in folks who hadn't had 360-degree endolaser. And after taking into account certain confounding variables through multivariate regression, these differences held up. So factors that they associated with final success, at least that affected final success negatively, were patient age. So folks who were younger, extent of RD, and 360-degree endolaser. And in the discussion, they talk about how the complexity of the case may influence the decision to use 360-degree laser. And the way that they accounted for this was through, again, multivariate regression. And, they still found that, folks with 360-degree endolaser didn't necessarily do any better and seemed to actually, to maybe do a little bit worse.
Amazing summary. And there's a lot of meat on the bone, or for the vegetarians listening, a lot of peanut butter on the spoon that we can work our way through. So I'm going to start with this, Avni. First, let's talk about why people chose to do laser. So Brian just finished. He talked about younger age, more breaks, more extensive detachment, surgeon ID. So some of those make implicit sense. Some surgeons just do this routinely. If you see more breaks, maybe you're more inclined to just laser everything because you're just worried. Maybe younger age, maybe you get in there. And again, younger patients tend to have more peripheral pathology maybe when they have a detachment. They're maybe more myopic, or they have a more abnormal vitreoretinal and interface, more posterior vitreous base. And again, a more extensive detachment, we can talk about hidden breaks and worrying that there's more things hidden. For you, when do you decide to use 360 laser? It's interesting that Brian said that surgeons, as they get older, they tend to do this more, which is, I think it's kind of interesting. What are kind of your criteria for where you say, okay, I'm going to actually laser 360 around the eye?
Yeah, I think some of these are in line with what I would do. I don't often do 360 laser, but if there are multiple breaks in multiple quadrants and large areas of lattice, those patients I do can, oftentimes do 360 laser in. If a patient has sort of an abnormal vitreous base, and I'm worried about that patient might be getting more extensive laser. Although most often I'm putting a buccal on that type of patient. And then a larger extent of RD. So oftentimes I will tend to kind of laser the periphery in the area of the detachment. And so a larger RD or a total RD or subtotal RD might be getting closer to 360 laser, but it's not really something I tend to do unless there really are, kind of breaks and lattice all over the place. The other thing, just from training, usually a recurrent RD where you can't find a small break, that patient is going to get 360 laser. But that's not really the situation we're talking about here.
And I'm just going to say a couple things I'm going to throw myself out there and you guys can criticize what I do. I mean, I do not routinely laser patients 360. The scenarios where I do it is, again, like you said, extensive pathology where I'm like, there's breaks in essentially every quadrant. I'm going to go 360. But I think the one thing a study like this cannot capture is how the laser is done. So there's very different styles of laser, right? There are people who paint in continuous mode. There's people who spray spots everywhere. There's the OCD people like me who make very, very beautiful, pretty rows. And maybe it changes nothing. And maybe it makes me feel better only, but maybe it influences the outcome. I mean, I try to teach my fellows, again, these are the Sridhar rules that have never been validated. I say, okay, if you're going to do 360 laser, make sure you're at least at the vitreous base and beyond, right? So there's no point in lasering and leaving the vitreous base uncovered. I like to take the laser out to aura to avoid donut detachments, especially if there is no buccal placed at the time of surgery. If I'm 360 lasering and there's a buccal, I like to stay in the buccal. And if I'm going to laser posterior to the buccal, my most important rule is the last or most posterior laser cannot be super, super hot because these can atrophy and form breaks, and then you create more trouble for yourself. So then the other thing that is interesting, and this feeds into one of the other really infamous and probably not helpful Sridhar rules, is what about these patients who are doing worse, right? So they get 360 laser and they have a worse final reattachment rate. Now you can talk about confounders. Brian referenced confounders. Maybe there's just more severe patients, more prone to PVR, and that's why they have a final success rate is worse. But how about the influence on laser and subsequent surgeries if you have to go back into an eye?
Yeah, so it's a huge challenge. So with PVR with 360 laser, I tell my fellows we're going to deal with Swiss cheese retina. When the traction develops, unfortunately, it'll exceed the adhesion force of the laser itself, and it'll start just popping off retina. And we're going to end up with just these micro holes all over the place that now we not only have to reattach the retina, we got to make sure all those little micro holes are addressed. And oftentimes, if it's a PVR case, we're already considering retinectomies. And one of the big things that I find with 360 laser patients is they need very extensive retinectomies to adequately address that the PVR. So I do see how with this paper they could say that 360 laser may trend towards having worse outcomes in those patients, just from my personal experience. I will kind of add my own thoughts on this paper. This is actually one that specifically changed my practice pattern. I used to be a 360 laser, and as this paper said, it's kind of very surgeon specific. And I came out of fellowship not wanting to miss breaks, and I would do routine 360 laser. And I had those experiences with PVR, and I said, this is a mess to fix when it does occur. And then I see this data coming out, and now this has actually been one of the papers that really directly changed my practice patterns. Now I've gone just to local treatment of the pathology and just leaving it at that.
Great points. And I'm going to tell a story. A very brilliant surgeon who'd be embarrassed to be named in this podcast, but who taught me. I remember I did a surgery when I was a fellow, and there was a beginnings of some inferior contraction, maybe some immature PVR. And I was like, oh, I'm going to barricade that. And he was like, well, why would you do that? And I'm like, well, I'm going to hold this back. And look, you can barricade certain things. But he was just kind of like, that's only going to make this situation potentially worse for what the reasons you talked about. Laser does not prevent PVR, I think. And in fact, it's probably inflammatory. And if the more laser you do, the more inflammation you induce. We accept the inflammation for the goals we want to with sealing breaks. And if we're trying to prevent breaks in an abnormal vitreous space, sure. But it's not going to make the retina stronger in areas where there's PVR. If anything, you're going to make your job harder and maybe make things contract more. So one of my rules that's unspoken when I'm working with the fellow is, let's say we have a chronic RD with some inferior PVR, assuming that we don't have to address the PVR in the first surgery. It's relaxed enough that we can drain the retina flat, but something we're just going to monitor and kind of observe. I usually in those cases say, let's minimize the amount of laser we do. We definitely want to laser the breaks and identify the breaks, but I'm not going to paint the inferior retina. And to your point, Sabine, if I have to do a second surgery in a patient and maybe in the worst case, do a retinectomy, it's going to be way easier and way cleaner to get that retinal edge nice and away from the retina, leave less of a nidus for future PVR if I just don't laser. I think the other reason 360 laser gets a bad rap, which is a little unfair, is again, the style of which it's done, not to harp on that point, but if it's really done posteriorly, you see all these pictures, sometimes a posterior ring at the equator or even posterior to the equator in the arcades, that's not necessarily fixing a problem. Yes, you may protect the macula, but you can end up with a donut or anterior detachment. hypotony, neovascular glaucoma, choroidals, all sorts of issues with that. So, Brian, any other points about this paper and the idea of 360 laser? And maybe you can weigh in on your practice pattern.
So, I think we all practice fairly similarly, at least, when it comes to 360 laser. I also don't routinely perform it. I will say that in cases in which I can't identify a retinal break, in which I'm most likely to put on a buckle anyway, I will tend to do 360 laser on the buckle, like you, Jay. If I'm going in to do a pseudophakic detachment and can't find a break, I may do 360 laser, but I try not to do it unless it's absolutely necessary. And if it's somebody who's got lots of breaks in lattice, sort of circumferentially, and it's not going to take much more laser to sort of complete the ring, I will do that, but try not to do it routinely. I think we've all seen cases where a patient sort of redetaches multiple times. Every time, they have a more posterior row or multiple posterior rows of laser. And when it comes time to do retinectomy, you're basically performing retinectomy, at the arcade or close to the arcade. And, I've learned to try to preserve real estate for what needs to happen. As far as the study goes, it for me sort of reinforced practice patterns. I don't see much of a need for 360 laser. I have partners, and I know doctors in the community who routinely will do 360 laser when doing macular cases. They touch upon that in the intro to the paper. I know docs who, when removing oil, will routinely add a row or two of laser, sort of at the most posterior edge, of whatever laser was already performed. I don't do that, and I recognize that there are data to support these practices, but at least for now, I'm going to continue not to.
Great discussion, guys. And I want to thank you for joining us for this amazing session. Dr. Sabin Dang, Brian Doe, Avni Finn, alphabetical order, sort of east to west, though we sprung east to include Brian there in DC. And thank you for joining us for this new Retina Radio Journal Club with VBS.